All right, good morning. My name is Joy, and I'm Dr. Porter's Urology Robotics Fellow, so thank you for showing all the fellow cases as a segue to this presentation. I'm going to be presenting our first live case this morning, which is a robotic retroperitoneal partial nephrectomy. CP is a 57-year-old female who is diagnosed with a small left renal mass. In April of this year, she began having asymptomatic microhematuria. She underwent a CT-IVP, which showed a 1.9 centimeter left lower pole mass, and MRI subsequently confirmed an enhancing solid 2 by 1.8 centimeter left lower pole lesion. As part of her hematuria workup, she underwent cystoscopy, which was negative. She was otherwise asymptomatic. She did not have any gross hematuria, flank pain, or constitutional symptoms. As for her past medical history, she was fairly healthy: hypertension, hyperlipidemia, and uterine leiomyomas. She had had a robotic total abdominal hysterectomy and bilateral salpingo-oophorectomy in 2011, as well as 3 C-sections prior. She had never smoked and had an allergy to cephalosporins. On exam, she was well-nourished, overweight, but in no acute distress with stable vital signs. Her BMI is 39.1. On abdominal exam, she has well-healed robotic port size and phalansteal incision, but otherwise no hernias. Her preoperative labs are unremarkable. Hematocrit starting as 39, normal creatinine of 0.8, calcium and LFTs were normal, coags were normal. She also had a chest x-ray as part of her staging workup, and that was negative. Dr. Porter's practice is to get a MAG3 renogram prior to partial nephrectomies to understand the split function. She had 48% on the left, pretty equal. Here is a video of the MRI. It goes a little quickly, but you'll see the lesion coming up kind of laterally about right there. I'll play it one more time since that was quick. So again, coming through on the lower pole laterally right there. Oops. Here is a coronal. It's a little bit more anterior than lateral here. You can see. Oops. So right there, you see the lesion, and then it disappears as you scroll back towards the spine. So on imaging, we have this 2 by 1.8 centimeter left renal mass. We calculated the nephrometry score as 7x. So for radius equal to or less than 4 centimeters, that's 1 point. Exophytic less than 50%, we gave it 2 points. Nearness to the collecting system was calculated between 4 and 7 millimeters, so 2 points for that. It was neither fully anterior nor posterior, so we gave it an X for that. And then the location just crossed the polar line, so 2 points. In total, 7X. I think we've talked a lot about patient positioning already this morning, but here is a shot of our positioning for retroperitoneal robotic partial nephrectomies. So we have the patient in a full 90-degree position perpendicular to the bed. We use rolled up blankets, so 1 blanket in the front anteriorly and 2 rolled up blankets in the back. And we find that this helps maintain a low profile so that you still have the entire abdomen exposed. So in the event of a transperitoneal or open conversion, you do have access to the abdomen. And it also precludes the need for any hard surfaces such as a bean bag. This also helps kind of maintain the patient in this full flank position. The other thing to note is that it's key to maintain a straight line from the shoulders to the hips, because if there's some slight rotation as we flex the bed, that will just accentuate the rotation and it'll limit the already tight working space in the retroperitoneum. Here's another position. Now the patient is in full flex. We do not use a kidney rest on any of our cases, in part concerns for rhabdomyolysis and whatnot. So we just maintain a full flexion of the bed and then place the patient in slight reverse Trendelenburg to make the space level with the ground. We place pillows under the legs and then use 2-inch cloth tape to help secure the patient again in that full flank position. Here's a drawing. Once the patient is draped, we mark out our landmarks. So here you have the tip of the 11th and 12th ribs. You have the iliac crest, and kind of right in the middle of the screen would be our mid-axillary line. Here you can see that he's marked what will be the camera port. This one will be the left arm, the right arm, and then the assist will be down here. Here's an image with the ports placed. So the head is up here. We have our iliac crest marked out here, tip of the 12th. We place one robotic arm laterally here, so at the apex of the tip of the 12th rib and the erector spinae muscles. Our camera port is the first one that goes in. It's a balloon dilation port and then a Hassan. And then here we have our left robotic arm, which is medial. This is in the anterior axillary line, at least 8 centimeters cephalad to our camera port. Our assist port then goes also in the anterior axillary line, about 8 centimeters caudad, so it's often fairly in a straight line from the camera port. And then lastly, we just have docking. For the SI, we do dock over the head, the patient's head, so that also maintains that line from the head to the shoulder and then onto the hips. And with that, we're able to get good working space in the retroperitoneum. And with that, we can switch to our live feed if we're ready.